The usual trigger to switch therapy is disease progression. Now, sometimes it's obvious and other times it's more subtle. I don't know with immune therapy if it's necessarily different than targeted therapy. With targeted therapy, sometimes patients, especially patients who respond, they're at their nadir of tumor burden for a while, and then they start to slowly increase. And it's a little new lung nodule here, and it's 2 millimeters there. And so from scan to scan, not much different, but over time, they're clearly progressing. That's a pretty common pattern we see. And sometimes those are the toughest decisions we make, when to pull them off a therapy that probably is still helping them and switch them to a therapy that we don't know is going to work or not. So I think it's an equation of perceived benefit and how much benefit is left, and also risk. If they're not tolerating a drug very well, a TKI will tend to beat people up over the months and years, then it makes it easier to switch to something else. The treatment options for relapsed or refractory RCC depend obviously on what they're refractory to. So if people are getting an immune combination up front, ipi-nivo, then we would generally turn to a VEGF TKI, in part because that's what's left. But also they're very active in that setting. We published some data at ASCO with axitinib, which we have a lot of experience with in a prospective trial, really quite active after immune-based therapy. If patients have a VEGF therapy up front, either monotherapy or with combination, they're also going to go on to a VEGF therapy. So right now, even though we're adding agents and shuffling a little bit how we approach patients, in the refractory setting, there's still work to do, because we're going to burn a lot of bridges up front, and we're going to cure some patients, but there's still going to be plenty of patients who get through that initial combination therapy and need more therapy. So that is, I think, an area of investigation moving forward.
It's now gotten a little bit confusing because a lot of our second-line strategies have been moved up to the front line. So in the future, in the very near future, we'll have patients receiving combinations in the front line, for example, with PD-1, CTLA-4. There, I think, in those patients who receive IO combinations, the answer to what to do second is pretty clear. Those patients have not seen a VEGF strategy. It's probably more likely to work in those patients, and so we're going to be applying probably single agents that we've used traditionally in the second line, like cabozantinib and axitinib, in those patients. And I think we'll see positive effects of that sequence. The other sequence is a little more difficult. When we move to VEGF PD-1 strategies, which will be more in 2019, the answer to the question of what do you do when patients fail both, we don't know. So we're going to need to do trials in that setting. And I have some worry, though, that it may be harder to treat those patients with second-line therapy, in part because if the data holds up in actual clinical practice, which we expect it to do, the patients there will be on VEGF for, say, 12 months, 18 months, 24 months, much longer than they were in the prior sequence strategy. So I'm not so sure that VEGF will work as well, anti-VEGF strategies will work as well in a patient that's been exposed in the first line to twice as much anti-VEGF than we have been traditionally doing. So we're going to need to do trials in that space. We're going to need to answer that question. Right now, we don't have a firm answer to that question.
I don't really think so much about staying or switching classes. I think that's more marketing than it is science, to be honest. I make a decision at the time I'm seeing a patient. What do I think is best for this patient? What gives them the highest chance of cure, the best benefit-risk ratio, et cetera. And then when that benefit runs out or the risk becomes more than the benefit, then I switch and look at what's available then. So I don't necessarily plot out, I'm going to use this mechanism and then that one and another one. I just, again, I'm not aware of data that's useful, and it's hard to do. It's hard to do because, again, I tend to make decisions sort of one treatment at a time.